What if one of the most common hormone conditions affecting women has been named wrong all along? Today, we're talking about polycystic ovarian syndrome and the new name recommendation to PMOS, or polyendocrine metabolic ovarian syndrome. So many women think PCOS, now PMOS, is a condition just affecting the ovaries or reproduction. But in reality, we're going to tell you the truth of the metabolic dysfunction and insulin resistance underlying this condition. So welcome to the Natural Doctors. I'm Dr. Katie Dinello, along here with Dr. Jennifer Stagg. Welcome to our show. So we're talking all things PCOS, PMOS.
Right.
But before we get into that, how you doing?
Yeah, well, I'm on with you with this marathon of recording here.
Yeah.
We're just did 2 shows yesterday and then 2 today. And of course we work on top of that and see patients and have family. So but we're pulling it off. We're here. Look at us.
We're just a little tired today. No, I know. I was home with my youngest one today, my 1.5-year-old, which was super sweet because don't get a lot of, one-on-one time when the older one is there. So, but it's like, so with us, I think one of the cool things about being a naturopathic doctor is we kind of get to make our own schedules. Like, we're not affiliated with a hospital, so we're not under these like crazy conditions of having to see, 20, 30 patients a day. So we get to make our own schedules, which is nice. So I pick a couple days a week, like full days to see patients. You see patients usually like mornings.
Yep.
And then you have the rest of the afternoon to do whatever you want.
Yeah. Which ends up being like, what? How did I pack all this stuff in?
Yeah.
And then I start adding patients in different places, and then I'm seeing them at night.
I know. That is crazy about
I'm trying to stop that. It's hard.
I tell you all the time. I don't know. I could never see patients at night.
I know.
It's really challenging.
It's not like easy, but then, people need me.
I know. Well, it's so true. And it's like, we do like to give people less traditional times because when you're working a 9-to-5 job, it's so hard to take time off to see a doctor.
It is, right? And they have limited hours, and I'm dealing with like teachers and people with like hardly any time that they get to take off and can't do it in the middle of their workday or whatever. But makes for an interesting day. But I don't have any patient schedule tonight, so that's nice.
So you're gonna get to sleep. I was thinking on my drive over here, I was like, today is the first day in weeks where I have not felt completely exhausted.
That is a good thing.
Yeah, I need to treat myself for chronic fatigue here.
I know we're on all the time talking about like, make sure you're doing your stress reduction. But it's hard. See, this is how we know that when we're working with patients and they're telling us about their busy lives, we're like, we're living the same lives they are too.
Yeah.
So then it's like, okay, you just have to find these little moments. Like, I'll get outside, I'm out watering my plants that I like need me also, but it forces me to go out and I walk. Like, I can't say that I just like worked all day. Yeah. I walk typically midday so that I'm getting that sun, which I like that intense. I think the sun is good for us as long as you don't get burnt.
Same.
So like those things really sort of like break up the day and help regulate and everything.
It's so true. And that is something I admire about you so much. And other patients need to hear is that no matter, you literally have the busiest schedule ever. You truly do. And you still get out for a walk midday almost every day. If that were me, like me, I work out in the morning.
But you were doing yours first thing. Like, you're up 4:30 in the morning doing this, which most people are like, I'm asleep.
but you stay up late with me. But that's the thing is like most of our patients are like, gosh, I try to get a workout in the afternoon, but so many things get in the way. You're a perfect example of like, you got to schedule that time, right? You just have to commit and get it done because
otherwise it's not going to happen. Right. But then I really love dusk walking.
Yeah,
like that's my thing right now, especially this time of year where we have these really late days and, the planets are out.
I know.
And like, isn't that so amazing? Like Venus and Jupiter and all these
Uh-huh.
alignments. That's so nice to see.
It's really cool to see. You feel way more connected to the universe, to nature. Like, I agree. Dusk time walking is superior.
It's good stuff.
All right. So today, PMOS, maybe before we even get started talking about that, what are you seeing in clinic these days in terms of maybe, any age range of women related to reproductive issues, whether it's metabolic driven or not?
Well, I mean, I know we're not going to get into a full bit on infertility, but I would say infertility. Like since COVID, young women that were healthy and got, especially like I have quite a few cases of women that basically got long COVID and now they're trying to have babies and can't. And they're in fertility clinics in New York, like seeing the best specialists. Luckily, one of them had a success story and she's pregnant, but it's just, that's tough.
Yeah, that is something I did not know before becoming a doctor and practicing, is how prevalent IVF is and how many people need it. And the worst part, and we're not shaming anyone, like, oh my gosh, thank gosh we have IVF, right?
Oh my gosh, yes.
Amazing.
But these clinics are full. Like these patients are reporting back. Top clinics in New York, they are packed. Like more than ever.
It's so true. And a lot of women that I treat for preconception care and fertility, they are so frustrated. Like they go to their gynecologist. Their gynecologist is like, oh, it's been a year, you can't get pregnant. Great, go schedule with fertility, an IVF clinic. Patients expect they're going to get this full comprehensive visit and all they're getting is, hey, when do you want to start scheduling next steps for IVF? And my patients are so surprised, so frustrated. And so we really want people to know that if you are struggling to get pregnant, go see a naturopathic doctor.
Oh my gosh.
Like,
absolutely.
I feel so strongly about this because the majority of patients, not everybody, right? But the majority of these women have high inflammation, insulin resistance, and that's what we're going to work on, right? And that's a huge reason for unexplained infertility. I will also say, if you don't have access to seeing a more functional or naturopathic provider, go on Instagram, follow Functional Fertility. This is my really good friend, Dr. Cleo Waddles. She just wrote an incredible book, Fertility Blueprint, I think is the name of it, but you'll find her. She has a wealth of information, so check her out because she really is a great resource.
Bringing light to that. That's
but this is a really good tie-in to PCOS, right? Because speaking about insulin resistance and metabolic dysfunction, PCOS is a very common cause of infertility, irregular periods. And so this name, polycystic ovarian syndrome, we have felt this name has just been wrong for so many. When I learned about this, I was like, this just does not make sense. Like, not everybody has polycystic ovaries with this condition, right? And so, the criteria for diagnosis has been, and this probably will be changing, but right now it still is 2 of the 3, the following 3, which is polycystic ovaries, which we'll talk about, but you see that on an ultrasound or imaging, and then high androgen levels like testosterone, for example.
Or symptoms
of that, correct? And then some type of menstrual cycle irregularity. Usually it's irregular periods, right?
Where you're having longer, like over 35 days.
Exactly. So you need 2 of those 3 to be diagnosed. Now, what's really interesting is that, first of all, polycystic is not even the correct term because
they're not actually cysts.
They're not cysts, right? So patients are like, oh yeah, I have all these cysts, and I'm like, actually, these are just several developing follicles, which then go on to become hopefully an egg that gets released, right, when you're ovulating. They're not actually cysts, so that it's just
they're
so
more
confusing.
like, I mean, they're immature follicles.
Right.
Like one of them should develop, and this is where there's a lot of that infertility, is you got a bunch of them that don't develop. Now you've got like increased ovarian volume.
Yep.
Yeah.
Yep. And that one main follicle is not developing,
Yep.
and then you're not releasing an egg, right? You're not ovulating.
Yeah.
So really interesting and confusing there, right? Now,
But that doesn't even have to be the case, right? So again, pointing out, like that can be one of the findings that you would see on ultrasound, that little string of pearls. But some women literally just have like long cycles and high testosterone without, and then they go for the ultrasound, looks totally perfect.
Yep. Yeah. So we are in favor of this name change,
Yes.
right? From PCOS to PMOS, because there's a strong emphasis now on the metabolic side, that metabolic dysfunction, that insulin resistance, which accompanies most of these cases.
Right. And which that's pointing out, we just talked about the diagnostic criteria. You might have noticed there's nothing in there about insulin, right?
Yep.
Like nothing at all. It's not part of the diagnostic criteria here. And up, like they say, maybe 80-90% of these cases have insulin resistance as part of the underlying, like really potentially some of the root cause, along with sort of neuroendocrine stuff. But yes, there are some cases that don't have the insulin resistance, which is more sort of like pituitary driven.
Right, exactly. So PMOS is interesting because we know a good amount of what's going on neuroendocrine wise, hormonally wise, but there's still a lot that we don't really understand. And there's a couple of pathways involved, but we're mostly going to focus on that metabolic piece. That
right, because it's
resistance.
the vast majority.
Yeah.
But we do want to point out, yes, we have like lean patients with PCOS.
Yep. Yeah,
and they're
exactly.
like kind of like, there should be maybe some categories here or something, or maybe that's even a different condition or something. But yeah, let's talk about for the vast majority of patients, women, they're dealing with insulin resistance, and that needs to be part of the core way we address it, right?
Yeah, exactly. So let's talk about, when a patient comes in, what is making us think, okay, maybe you have PMOS, right? Typically it's, irregular cycles. Like that's first kind of what I'm thinking, like, your cycles are long, you're not getting your periods. Or maybe somebody comes to me and they're like, we've been trying to get pregnant, we can't. It's like, okay, maybe you're actually not ovulating here, even though you're getting a period, which is possible and very confusing.
Yes.
So that's the first thing. Second thing is symptoms of androgen overload or excess, right? High DHEA, high testosterone, which we did get an Instagram comment. People are wanting us to talk about DHEA. So maybe we'll have to do a little bit more about that.
We'll have to do that. That's a good idea.
DHEA is the precursor to testosterone. It's how females make their testosterone. So either of those could be elevated, contributing to those irregular cycles. But other symptoms of that might actually be acne.
Right, and more sort of like a hormonal acne, right? So it's going to look different than just like, oh, you're getting an occasional breakout or something, right? Like it's more that hormonal acne type. And then male pattern hair loss even, and
thick hair
on the face where you don't want it.
Or
even on the chest. So
absolutely.
like severe classic sort of PCOS is hair potentially growing on your chest, under your chin at a young age. We're not talking about women. We know you get into menopause, perimenopause, you get some androgen excess. This would be earlier in life, right? Like you really shouldn't be getting that, to that degree. And then we're talking about also as a typical patient, that sort of central belly fat, right?
Exactly.
Like that's the screaming PCOS picture.
Definitely.
Can't lose weight, started gaining weight. And this often happens, like all those patients where it's just like so obvious. They'll say that like they hit puberty and all of a sudden they started gaining weight, they have really bad acne, like it's that sort of profile, and they started having irregular periods. Right?
Totally.
Now, it doesn't always have to be that way, but that's just like your classic case.
Definitely. Yeah. So these patients, again, we want to emphasize it is so much more than just a reproductive condition. Unfortunately, that is, really where it's been concentrated because women, of course, will go to their gynecologist because they either can't get pregnant or they're like, something's going on with my period.
Yeah.
And unfortunately, conventional medicine is not asking about insulin resistance. They're not testing for insulin or metabolic dysfunction. They're simply saying, okay, go on birth control to regulate your cycle. And that is the extent of it.
Right.
So this name change hopefully will encourage conventional medicine gynecologists.
Right, to get endocrinology involved.
Exactly.
If we think about from a conventional standpoint, typically the referral is straight to gynecology. Sometimes you'll see patients that have seen endocrinology.
Sometimes.
But it really needs to be more endocrinology that has a metabolic focus, right? The diabetes, metabolic practices.
Yep, exactly. Because, you know, in addition to insulin resistance, patients with PCOS also have a higher risk of cardiovascular disease. And so we really want to make sure we're screening patients for that and lowering their risk for that as much as possible as well.
Yeah.
Okay, so when we're thinking about diagnosing, or not necessarily diagnosing, but labs and workup to really assess the fullness and completeness of this condition, where are you starting in terms of that with patients?
Right. So for sure, we're thinking about testosterone, right? So that, and DHEA. So we mentioned the androgens. Then we're looking at that metabolic picture. So here we have fasting insulin, so important. People are just so sick of us talking about that.
I know. No, I don't think they are. I think we are just sick of hearing
We're sick
ourselves.
of listening to ourselves talk about it. But it's so important.
Yeah,
so fasting insulin. And then also a lipid panel to look at triglycerides and HDL. So then screening for the elevated triglycerides, as you know, and low HDL. Those are the big ones that are really looking at that metabolic picture. Hemoglobin A1C comes in handy there too. Glucose, you can do a glucose, but a lot of times the glucose is going to be normal here, and you can still be insulin resistant.
It's so true, especially if these women are in their 20s, right? Like they've not been alive long enough to have that intense glycemic load. So, absolutely.
So we'll see that. And then potentially doing some more endocrine workup, like looking at, you know, prolactin, LH, FSH, all that sort of stuff.
Absolutely. Yep, I'm with you there. Yeah, I would definitely say I'm thinking about a couple of PCOS patients I saw in the last couple of weeks, and I saw high triglycerides on 90% of them, and like young girls too, you know, 20s, early 30s. So
right, because that's going to show up for sure.
Yeah. All right. So we've got like 10 minutes left here. Let's really focus on treatment and what we're actually doing for these patients. So I would say both of us are probably starting on the lifestyle piece, right?
Yes.
Super important.
For sure.
And so what are some nutrition tips that you're giving patients to get them going on kind of treating their PMOS?
So people are going to get sick of us again.
I know.
Because we're going to talk about glycemic load. So we really, because it's an insulin resistance that for most of these women, now there's definitely exceptions here, and then we, you know, we're going to treat that a little bit differently, or a lot differently. But from a nutrition standpoint, we need to think about how the food choices, when we're looking at starches and carbohydrates in the diet, serving size, how high it's spiking blood sugar, and really, you know, educating patients about that so that they're really, you know, aware of their food choices, that, you know, certain things like sweet potatoes, if you eat too big a serving size, it can spike your blood sugar when you're insulin resistant.
It's so true. We've gotten some backlash on our Instagram here, which I get it. I totally understand, you know, us saying foods that are seemingly healthy, right? Like a sweet potato, for example. You're right, you guys.
Right, we eat them. They're in our households.
Yes.
FYI, we do eat sweet potatoes.
So healthy. They're great. We have nothing against potatoes. But if you are already insulin resistant and you're not paying attention to that serving size, it's a carbohydrate. Of course, it's going to make your blood sugar go up, right? And if you're doing that repeatedly, day in, day out over time, you're not going to help your insulin resistance. So again, it's not about food foods that are like good and bad, healthy or unhealthy. It's about really looking at your full diet and making the best choices based on what your blood sugar is already doing.
Yeah. So we're looking at a whole foods diet that's low glycemic load. And then that is, by nature, a whole foods diet would get rid of all the ultra processed food. Right? So just that needs to go out the window because it's just so bad for us in general. No one should really be eating that. So whole foods, low glycemic load, thinking about omega-3s here a lot. And even with testing, I would be testing an omega-3 level as well.
Me too. And especially for that cardiovascular component, that gets important as we age, of course.
Other healthy fats, nuts and seeds.
All that. Walnuts. I had a nice handful of walnuts before I came in with my green tea.
Very good. Polyphenols.
Exactly. We've been talking a lot about that. But yeah, fatty fish like salmon. I get this question a lot. Patients are like, well, I eat fish, but it's like the white fish, not the fatty fish. The white fish is not going to have those rich omega-3s like salmon, mackerel, sardines.
Right. Like you got to go. There are some fattier white fish, but a lot of the white fish people eat is not going to give enough omega-3s. And you see this also when you're testing patients that like knowing what they eat and then doing omega-3, is that enough? Right. Like I did this test on myself and I eat fish maybe like 1 to 2 times a week. But I eat a lot of seeds. So I'm eating flaxseed, hemp seed, walnuts, and just off fish oil for a couple of months just to see. And my omega level was 7.0, which is great. Most people say that's amazing. But we want it to be 8.0 and above for optimal, especially for cognitive health. But that's just, okay, well, can I eat more of those? I added a fish oil pill then. Because I'm doing pretty good, I think, from a dietary standpoint.
And I will be the first to admit, I do not eat fish. I do not like it.
Well, you're a vegetarian.
But I do eat so many nuts and seeds, but I do supplement with a fish oil because it's hard to get those levels up. So, okay. And then let's talk about the exercise piece here because, not all of my patients, I don't want to lump all of my PMOS patients into one category, but I definitely see lack of movement and more sedentariness as a common component. So, and it's no shame, like truly.
And that's just a common thing we see in general in everyone.
It's hard. We talked about this at the beginning of the episode, right? Like it is really hard. I'm up at 5 to work out. I never want to do it, but I do it. You're making time midday, so it's tricky. We get it. But we have to remember our bodies are designed to move. Like we literally are beings that are meant to move. And so we have to do that. It doesn't have to be anything super intense or crazy, but just get your body moving. Absolutely. It matters. If we wanted to get a little bit pickier here, strength training again, because we can't overemphasize how important healthy muscle is. Muscle is that reservoir for sugar, right? So when sugar is in your bloodstream, insulin tells the muscle cells, hey, we've got some sugar in our blood. You guys need to take up this sugar to make energy. So if you have more metabolically active muscles, if you have larger muscles, healthier muscles, they're going to take up that sugar, right?
And then you're going to mobilize that glucose when you're exercising too.
Exactly.
So then even things like I have a patient I just saw this morning and we've been working together. She was like, she felt she didn't want to go on medication and we were working on gut health with her. She's not PMOS, but just an example that she's prioritizing exercise, prioritizing diet, and she's walking after her meals. So the 5 to 10 minutes plus, getting, I think she said 15,000 steps a day she's counting. Amazing. And she was over 200 pounds. She's down to 160. And like 5 pounds in the last month. Like she is just steadily going down. So it's like, it's doable. And this is a woman who's over 50.
There you go.
Like it's not impossible. You can do this with diet, with lifestyle.
It's so true. It's so true. Okay. Let's talk about a couple of other supplements really quickly. We're not going to get into it too much, but besides fish oil, is there one or two other supplements you like?
Yeah, because of the insulin component, then berberine, of course, always comes to mind. But specific, a lot of times with these patients, we're thinking about inositol here, right? Like I think that's pretty common with naturopathic doctors to use inositol across the board.
Yep, definitely. There's some really nice literature on inositol for PMOS, both the insulin piece and helping to regulate periods.
So very evidence-based. So we can rely on that. And magnesium also, I think, comes in handy here.
Yep. Yeah. Okay. Couple listener questions that we have here. So I think my favorite one probably is, what's the most important takeaway that we know about this shift? So like we see this headline, PCOS to PMOS. I think the biggest takeaway to remember that if you get diagnosed with PMOS, it is not just a reproductive condition, right? We really want to focus on the whole body, the root causes of that metabolic dysfunction, that insulin resistance. So often when a woman gets diagnosed with this and then comes to see me, I say, hey, did you know that this condition is also associated with cardiovascular disease and insulin resistance? And they're like, what are you talking about?
Yeah.
Like, no, this is my ovaries, this is my periods. And so it can be really shocking for women. So, just keep that in mind. But remember, it's all good. Some simple lifestyle changes doesn't take a lot.
That's for sure. Yeah. So diet matters here. And I guess that's the question. You'll get patients that come in, they're like, is there some way I should eat for this? Like, could diet make any impact here? And I think this name change is bringing light to, my gosh, like your diet does matter. And, a lot of patients, as I said, like classic symptoms, have difficulty with weight, right? And so they often come in very frustrated that they can't lose weight, right? And they're even dieting and not getting results. And it's because the way that they're dieting is not appropriate or effective for an insulin resistant person.
Yeah, it's so true. And then the other thing I'll highlight there as a takeaway is, it's okay if you end up going on birth control for various reasons, but remember, it's not getting at the root cause there. It's going to allow you to have regular cycles, but it's not going to help any other component of that PMOS picture.
Right.
So,
well, there's that metabolic part.
Right. Yep, exactly.
Yeah.
All right. I think we did it.
I think so.
Thank you so much for joining us tonight. We are the Natural Doctors, Dr. Katie Dinello, Dr. Jennifer Stagg. Make sure you subscribe to our YouTube channel so you never miss an episode.
Adoption is a journey, and in any parenting journey, there are difficult things and there are really great things.
We did our training through DCF and we felt really well trained and well prepared. The social workers become like family.
We love them. They made such a huge impact in our lives. We have gotten so much support and so much love through DCF. You're never prepared for parenthood, but we felt as prepared as we could be. It's a joy that we hope others share as well. If you think that you are ready to foster or adopt, please go to ctfosters.com.
Like us on Facebook. Search Nutmeg TV.